I think to me this is one of the most interesting area. Is the one where there is least evidence, unfortunately. So we have to build this evidence slowly, because I think to me the most risky area is this area, because if you have complications, the first remark will be why you didn't place a stent. So we have to be very careful not to ruin this baby. So Bernardo Cortese is going to. Oh yeah, we have questions. Yeah, can we go the first?
To the audience?
Well, we still don't have enough people. Should we?
We can do it in between, no?
Yeah. Can we do?
Okay, started already.
Okay. In what percentage of patients with de novo lesion do you use DCB? Okay, 40. But you know, in
are equal three percentages.
Yeah.
Okay.
30%.
Yes.
I think
30%.
it's fair. But you could even rephrase the question: in what percentage of patients with de novo lesion 3 millimeter or bigger do you use DCB? Next. When do you plan to treat a de novo lesion with DCB? What is your crossover rate to drug-eluting stent? What is your...
Well, I think that perhaps about 10%, 15% of the cases I have to cross to attend, mainly because of an important section.
Oh. What is your 10%?
More than that. I'm using more frequently every day, and I think it's more or less the rate.
In my case, probably around 10 and 20%, probably.
So here we see 5-10%. I think is reasonable. 5-10% to me is reasonable. What do you think?
I think this is probably real world. I think it depends a little bit what is the balloon you're using for pre-dilatation. I think if you just use a regular semi-compliant balloon and blow it up, then probably you have higher rates of crossover. And if you start with a gentle little inflation and then you go over to the specialist balloon, this rate could be lower, I think.
I think the problem is that the people that are working now in the cath labs are not familiarized with the treatment with only balloon. So always they need to see the result stent-like. So it's very difficult for the young interventionalists to stop with a lesion with 30%. For example, that will be a good result for the balloon, but it's not a stent-like. So probably we need to form in this role, probably.
Going back to the time of angioplasty, when we did not have stents available, when we had the dissection, before sending the patient to surgery, we tried with a bigger balloon, which is something that young people forbid because they think they're going to make the dissection bigger. But the only fear is that if you don't have stents in the lab, if I don't see any stent, that's I don't do that. Okay, let's have another question. When you are in doubt whether your DCB result is adequate, consider the possibility of a bailout death. I simply rely on the angiographic appearance, dissection, TIMI flow. I always wait in the cath lab a few minutes, few seconds. I use physiology. I use IVUS.
Can you use more than one answer?
Most probably you should use more than one answer. So, I mean, sometimes but I rely on appearance. I think makes a lot of sense. That's the reason why 50%. I wait. I think the only thing that should not be done, in my opinion, is to keep on injecting. Because forceful injections, especially with the assist device, can
destroy the vessel.
Yeah, and we had some cases where we did OCT with the dissection and it's problematic.
Yeah. But the opinion of the experts?
What do you think? What is your opinion, your practice?
Well, I think that mainly rely on the angiography appearance in many cases, but if you are not sure, you are thinking that perhaps there is a problem, or perhaps you can use the OCT. But I think in the majority of the cases, with the angiography, you can take the decision.
I think so.
So in my case, probably it's a combination of both. To rely on the angiography, of course, you don't have major dissection, the diameter stenosis is acceptable, and then also it's important to wait for some time. Sometimes in the cath lab we have to rush because we have pressure of other patient waiting, and I think it's important in this case with you are not sure with the result, to wait for some time, give some nitro, and check again the angiographic result. And if you are still in doubt, to use intracoronary imaging I think
it's amazing that physiology got 0%. Yeah. But maybe in the future, with the availability of QFR, people will use it more. Because you don't need a dedicated wire, you can get it immediately.
I think the physiology, you are in that because you have a stenosis, no? But if you are thinking about a dissection or something like that you are not sure, that by physiology, I'm not sure if it's the best.
Yeah, but in our experience...
Probably the mechanism that you make the trouble that decide it is a good result or no. If the bad result is due to the residual stenosis, the physiology can play a role.
I think
if it's a dissection, probably not. No, probably.
I think the physiology, if you have a zero gradient or 0.2, 0.3, even if you have a dissection, means the dissection is not occlusive. Okay, can we see next? In a stable patient treated with DCB, my preferred antiplatelet regimen is single antiplatelet, dual antiplatelet for one indefinite, single antiplatelet indefinite, dual antiplatelet 3 months, single antiplatelet, dual antiplatelet 6 months, single antiplatelet indefinite.
But you prefer regime?
What is your preferred strategy?
Of course, it depends on the scenario, but in stable patients, one of the advantages of these balloons is short regimens, so I would go for 1 or 3, at most 3 months.
Yeah. What is your strategy?
Well, our strategy usually is between 1 and 3 months of the APT, depending on the acute coronary syndrome or stable or whatever. Usually is that.
Yeah, I think if it's a stable patient, 1 month is...
Well, it depends on the patient.
Yeah, if it's a high bleeding risk, as shown, you can even use a single antiplatelet.
High bleeding risk.
Yeah. Next. Okay. I think we go to Bernardo. Bernardo Cortese is going to give us some highlight about the Italian experience with DCB as a default strategy.
Yeah, well, I couldn't find anything about Italian in the literature, so just talking about why, for me, DCB should be the default strategy. We use DCB in around 70% of our cases, also considering some blended cases, and 40–50% of only DCB in our casuistry. Okay, so Raban cleverly previously went through this point. Okay, we still are a little bit back as compared to cabbage. Okay, this is almost perfectly done PCI with modern devices, with physiology, but still FAME3 in the complex lesion setting is a little bit behind than cabbage. We didn't reach the non-inferiority to cabbage at 1 year. Then we will see on longer term follow-up how will be the outcome. Maybe DCB can be a possible response to this, also because in the vast majority of the cases we have TLF, we don't have other events in the PCI arm. And then in the complex setting, again, calcific lesions. Yesterday we had a very interesting sessions dedicated to calcific lesions. You can see here that currently available DS are not good. They are not good at all. We have a lot of devices now, but still placing metal in a highly calcific lesion is associated with impaired outcome. We have to keep this well in mind. Quite the same for small vessels, for long lesions. There is one nice study that, for the sake of time, I didn't put here, the Grand DS registry, which is showing that the longer the stent is, the worse is the outcome in our patients. With DCB, we want to counteract on the initial barotrauma that we are doing in our patients, and we are interrupting it. So what is important is not to have the drug staying there for months, but we need it to stay there and work for the first weeks, 1 month, 2 months, that's enough. Because there, at that time, we will interrupt the restenotic process. And then we don't have a prosthesis. We have seen this study, so I will go fast. Obviously, in these meetings, some slides are repeated, but I think it is important to deliver, to convey an important message. One is that if we have multivessel disease, we don't have to think only at paving the coronary arteries of our patients, because we may use a blended therapy. This name I took from Patrick. I like it more than hybrid as well. And this study is very easy in how it was done. It's a retrospective analysis of 2 prospective studies, propensity matching, blended therapy versus full DS. In the blended therapy, in 2/3 of the length of the lesions, a DCB was used. Okay, so not long DS and small DCB, the contrary. The outcome is here. The Kaplan-Meier curves are quite reassuring for those that are believers of DCB. Maybe cardiac death, which is significantly higher in the DS, can be a play of chance, but MACE and obviously the risk of bleedings and target vessel vascularizations are there. So information from this study are quite clear to us. And then we have the long-term data. This is one of the most interesting topics about DCB now, this year, because many studies are coming out. This is a comparison by propensity matching again with the recent stents, thin strut stents versus DCB in ISR. You can see here at the median of 3-year follow-up, there is no significant differences in terms of all of the clinical outcome, composite and single items. Long-term follow-up of basket small 2, again, this is still the largest study, randomized study on DCB at 3 years, no differences in terms of MACE as compared to drug-eluting stent, and also if we split only DCB versus science, again, no differences. We have also the 5-year follow-up of a small mechanistic study. We have seen that in the previous presentation. Restore at 5-year, again, no differences in terms of MACE between one of the most used stents and Restore DCB. And we have also this data from Piccoletto 2, recently published. For the first time, a drug-coated balloon is better than a drug-eluting stent in terms of MACE during a long-term follow-up. At 3 years, we have a reduction of MACE. This is not the primary endpoint of the study, which is late loss, being it a mechanistic study, but MACE are significantly reduced, as well as vessel occlusion, acute vessel occlusion, or subacute or late vessel occlusion, which is 0 in the DCB arm. So again, quite reassuring data. But please take a momentum in analyzing the curve, which is not anymore a curve after 18 months in the DCB arm, the red one, because it's flattening. So this is very fascinating in this technology. I think that we need to investigate better and invest more on this technology also for this. Another topic, again, coming, high-bleeding risk patients are so many, either those with a bleeding and active bleeding, but also those at high risk. So this is why parallelly it was a fight that Thomas won, actually, because he published his paper 1 month earlier than us. But the main message is the same. In this study, we wanted to analyze the performance of 107 patients treated only with single antiplatelet therapy from day 0, okay, because they were at high bleeding risk. You can see that they were with anemia, hemoglobin was less than 10, AF 43%, history of bleeding 83%, anticoagulation in 50% of the patients. So we analyzed this cohort of patients and compare it to the de novo patient population. In hospital, no significant differences in terms of MACE and bleeding. And also at 1 year, there is no differences in terms of MACE, no acute vessel occlusion in these single antiplatelet therapy patients, with some of them about 47% left with a dissection, and interesting lower bleeding, significantly lower BARC 2 to 5 bleedings in the single antiplatelet therapy. Then we have more data from all comer registries. This is the ISMU registry, the largest registry on DCB. So far, it's an independent prospective registry of Magic Touch sirolimus-coated balloon. We recently presented a 2-year outcome during EuroPCR. TLR is the primary outcome. These are the centers involved from several countries, 2,123 patients with 2,440 lesions enrolled into this registry, which is taking de novo lesions in 55% of the cases, and also ACS in a little bit more than 44% of the cases. So it's, we also have 5% of STEMI patients. This is the 1-year outcome with a TLR primary endpoint of 5.9%, MACE rate 9.9%. All of the events have been adjudicated by an independent CEC. And here, if we split the outcome between ISR and de novo, we can see here quite a similar performance with other paclitaxel-coated balloon. TLR rate is high with this device in TLR, in ISR. It's 10.5%. I have to say that only in 10% of the cases intravascular imaging was used by the investigators, but still we have a lot of things to learn for this very complex disease. But the performance in the de novo cohort was very good, with a 2% of TLR, 4.9% of MACE, and this is a 2-year outcome recently presented at EuroPCR. The TLR per lesion is 8% in the whole population, cardiac death 1.4%, overall death 4.9%, spontaneous MI 3.3%. And again, if we split the outcome between ISR and de novo, again, we have a TLR rate which is very low. From 2%, it came to 3.2% in the de novo population, and in the ISR population from 10.5 to 14%, which is, I would say, quite reassuring data, with not a late catch-up phenomenon that we have seen already with other devices, and also with some drug-coated balloons after the first year of follow-up. So quite interesting data. Obviously, we will need to analyze them deeply and to better understand. And then the future steps for what it pertains to our group is to understand and compare drug-coated balloons with a drug-eluting stent. This is what we are doing with Transform 2 study. This is a non-inferiority trials with a clinical endpoint. The primary endpoint will be target lesion failure, and the co-primary endpoint will be NACE, where we hypothesize the superiority instead of the non-inferiority of the DCB. And then we will follow up these patients up to 5 years. This is the flow chart. We are accepting lesions between 2.0 and 3.5, so it's not only a small vessel disease study. I hope that only a minority of the patients which are being enrolled will have a small vessel disease. We will prepare the lesion, and we will compare this to devices after correct lesion preparation, Science and Magic Touch. As I said, primary endpoint is TLF at 1 year. We are accepting lesions up to 50 millimeters, and I want to remark this, we will follow up the patients up to 5 years to see how is the outcome on the very long term. And for all of this, we will enroll more than 1,800 patients. So something that we need to do regarding the clinical reliability of this technology. These are the countries. We are enrolling patients also here in Spain with some pretty good performing centers. And this is the future. These are the other trials that are enrolling patients with drug-coated balloons, randomized with a clinical endpoint. There are many settings, there are many trials, a lot of them are investigator-driven, only few of them are sponsorized trials, so this is a clear message on how important is this device and this technology for our community. My conclusions, DS are good, but they are not perfect because they go on little by little, 2% per year, 2 to 3.5% per year of events after year 1. DCB are a valuable tool for the daily armamentarium of any cath lab because they are safe, for sure, we have seen this, but they are also effective. You should choose your own sirolimus or paclitaxel DCB according to the preclinical and the clinical data that this device has. And currently ongoing trials will give more fuel on the role of this technology in a daily, not a niche, but in a daily routine practice. Thank you for your attention.
Thank you very much, Bernardo.
Antonio and co-moderators, I need to go because I have the pickup. I don't know if you want to discuss it now or otherwise I have to rush.
Maybe if there is any specific question for this talk.
Or do you have any questions?
Congrats for your talk. It's really nice to see all this data. And I will to ask you, what is your approach exactly? Because you wait some minutes or not? Do you remove the wire? Do you decrease the flow of injections if you remove the wire while you are?
Yeah. This is an important didactical point, so I would have replied at that question 1 and 2, because only 1 is not enough in my opinion. Just to assess in a single view the immediate result of DCB is not working. I remember of a nice talk that I had with after Patrick's meeting with Greg Stone. He told me that decades ago he did a study where they analyzed the recoil of POBA. But they analyze it after the first minutes and then during the time. After 10 minutes, after, I don't remember, 1 or 2 hours, and then after 1 month, 6 months, and so on. And what he said is very reassuring for us because he said that if you have recoil, in the vast majority of the cases, you have immediately in the first minutes. So this is why you should wait 7 minutes, 8, well, I don't know why 7. Because it was 10, but then we reduced it because we always rush. So some minutes, and observe it in an orthogonal view. So this is what I strongly suggest.
Any other?
No.
Okay. I think
okay. Thank you. Bye-bye. Thank you.
Very much.
So let's move on to the next talk that's made by Simon Eccleshall, the experience of UK.
So, Good afternoon. My name's Simon Ecclesall from Norfolk and Norwich Hospital in the UK. Thank you very much for the invitation. So that was the title of the talk. Can it be used as a default strategy in the UK? I think I'm about to speed up your programme, because the answer obviously is yes. So I'm going to talk a little bit about the history of our practice in our department rather than Bernardo's lots of trials that he's done, because he's very clever. So in 2013 I started doing a lot more DCB work, having been using it already for a few years, and this was due to a number of things that came together at the same time, including having some visits to Bruno's cath lab. Thank you very much. For the next few years I then progressed my DCB use, and you can see here the line at the top is my DCB use as a percentage of all of the cases that I was doing, and that's mirrored in the drop off in the stent usage, so that it was something over 80+%. This was mirrored by my department, who between 6 to 8 operators depending on time scale. By about 2015 we were DCBing and stenting at a ratio of 1:1. So in the UK we are very heavily regulated, because that's what Brexit does for you. It's great, isn't it? Anyway, so we are watched by our national bodies, and we actually have to go and listen to the audits that happen every year. So this is 2015 data for what's called the British Cardiovascular Interventional Society. So every case we do in the cath lab gets reported online, it goes to them, and then they collect all the data. And then they present that data every year. So one of the many slides that goes up every year in January in London is percentage of stent use in each centre. And you can see that there's lots of centres doing what everybody was doing back then, putting lots of stents in all the time. We're right down there. So they actually had to reinvent the scale down the side in order to fit us in. And obviously when this was first presented, this is the first time that this was seen, there was quite a lot of murmuring in the audience. So we're monitored nationally. Between 2015 and 2018, which is those 3 years I just told you that we converted to 50-50 DCB and stents, there were no outcomes because the NHS ran out of money and the people that were doing it had to move. But then when we did get some data, we got all 3 years in one go. And there's two things that our national bodies are interested in. One is the acute vessel closure rate, and the other is the risk-adjusted 30-day mortality rates. If your mortality rate is too high, you will get a phone call as an individual operator or a visit as a centre to find out what's going on and what you're doing wrong. So obviously when we knew we got 3 years worth of data coming, when we had very subtly and gently changed the way we were performing our angioplasty, we were quite interested to find out what was going to happen. So this is our centre for those 3 years. That's the rate that we should have been killing people at, or saving people, depending on what terminology you like to use. So this is risk-adjusted 30-day mortality for all our angioplasty, except those patients who were intubated or shocked when they went on the table. So we were an outlier. We weren't killing enough. We were better than 2 standard deviations better for our 30-day mortality for those 3 years, when what we were doing out of the ordinary was just not putting in stents. So we thought that that probably meant that it was quite a good thing that we were doing. Because of the fact that we do have to collect all our data, we then started thinking perhaps we should start interrogating it and getting some publications out of it. So this is one of the first ones that came out, which was essentially on the back of the ESC saying dual antiplatelet therapy was recommended for 6 months in all DCB work, and I knew by this point in time we certainly weren't doing that, and most of the other people in the room who use DCBs weren't either. So we went and looked at a cohort that we found within our database, all elective cases, all only 1 month of dual antiplatelet therapy, and then we went to go and see what happened to them at 6 months, as in when they should have stopped their dual antiplatelet therapy. And the answer was absolutely nothing happened. There were no events at all. So we thought that 1 month of dual antiplatelet therapy was safe, and we carried on. One of the other things we did is, because people were always worrying about this concept of you're not putting a stent in, it can't be safe, you need to keep an eye on these patients, Again, in the UK, we have a massive drive to get people out as quickly as possible. So our elective programme is nearly all day case angioplasty. So we looked at a cohort of our patients that we were sending home within 6 hours of their elective angioplasty. 100 patients, 50 of them angiographically had good going type A, B and some C dissections, and again it was safe. So we got a little bit more ambitious then and thought there must be more things in our database that we can be looking at. So that's the slide I showed you before, telling you that there's all these outcome measures, and actually there are 3 that we can now look at. NHS Digital gives us mortality for any patient that we've treated if we ask for it. Hospital episode statistics tells you all about all of your patients that have been admitted at any point and what all the diagnoses were. And the NICOR data set collects people that might have had an angioplasty, for example, in another centre, so otherwise you wouldn't know about it, or had gone and had surgical revascularisation, and we're not in a surgical centre, so again, we wouldn't know about it. But if you have a large cohort and you go to these bodies, you can, if you pay enough money, get the data. So we started doing that. This is one of the first things that we did. And this was around the time that there was a lot of concern about paclitaxel and late mortality. We found a cohort of patients who'd never had a heart attack and never had an angioplasty, and they were undergoing an elective procedure. So we thought this was the cleanest cohort you could ever find within our database. We then matched them, so there were 429 in each arm, DCB only or stent only. And as you can see, there's a significant difference in the survival rates. Stents are carrying on dying at a faster rate, and a bit like Bernardo just showed you earlier, DCBs are still having an event rate, but they seem to be plateauing off somewhat. So we then looked at a larger elective cohort and compared those to our stented cohort, again propensity matching, tracked them out to over 3.5 years. There were no difference in any of the outcomes. We then looked at our left main stem cohort, which we'd now been treating for quite some time. The outcome of that was, compared to stents, numerically less cardiac death, target vessel MI and TLR if you use drug-coated balloons rather than stents. We then looked at our STEMI cohort, and this was published much more recently. Similar answer. So these are our first presenters to our data set. 450 with STEMIs in the DCB arm, over 600 in the stent arm, and they again were matched. There were no differences. The most recent thing that we've done, we haven't yet published this, but we presented it literally last week at PCR, and I thought, you may have noticed earlier, I'm very keen on bifurcations. This was from our same data set. This is us looking at either drug-coated balloon only bifurcation angioplasty or stent only. So it's covering a 4-year period. We have over 1,000 DCB only bifurcations and over 1,000 drug-eluting stent bifurcations. You can see that there are some differences. There tends to be more ACS work with the DCBs, and I think this reflects the fact that our department don't like putting stents in thrombotic bifurcations. There are also more true bifurcations in the DCB arm, more calcification, and the vessel diameter was a little bit smaller. And all of these things obviously predict a worse outcome. So I hate these composite endpoints. This is bifurcation-orientated outcomes. So when you lump them all together into this composite outcome, there is no difference between the two. And the multivariate analysis on the right shows there's nothing in particular turning up. When you look at cardiac death, although statistically they are the same, if you look at the multivariate analysis, there are a few things that would suggest that perhaps there are differences between the two groups. You move on to target lesion revascularization, and those things that are within the multivariate analysis suggesting there might be a problem include the use of drug-eluting stents, and that's the same with target lesion myocardial infarction. So, can DCB be used as the default strategy during PCI? From a UK experience, what I'd say is DCB should be used as a default strategy during PCI. Thank you very much.
I think we leave the question after next talk.
Okay. So now Dr. Jäger tell us the experience in Switzerland with the drug-coated balloon.
Okay, thank you very much. Unfortunately, I have to take you down to earth. You have heard a lot of countries where there are lots of DCB interventions. Switzerland is a little bit different, not only politically, but also regarding interventions. What we are very proud of is that Andreas Grunzig, he worked in Zurich. This is the same city where I work, when he did his first angioplasty 45 years ago. And just to show it to you, I like this very much. The picture above is the LAD, the proximal LAD that was treated with POBA at that time. And 23 years later, this was the long-term follow-up of this lesion. The funny story behind it is that Bernhard Meyer, who was the former chief of Inselspital, the largest hospital in Switzerland, he was a student at that time in the cath lab in Zurich, and he was present there, and he did the angiography 23 years later on the same patient. So this is Switzerland 45 years ago. Our data in Switzerland is not collected properly. These are the data, the self-reported data from the registry, the PCI registry. The working group Interventional Cardiology is collecting every year, and currently I am the president of this working group, and I had the opportunity to publish this with a fellow, and you see that these rates of PCI angiographies are increasing. We have like 50,000 coronary angiographies in Switzerland, half of them are PCIs, and so forth. These are the centers in Switzerland, like 100,000 centers doing PCI in Switzerland. There are some small centers, just 500 cases, 200 PCI cases. So there's a lot of interventional cardiologists. But if you look at this, basket small 2, we spoke about this a couple of years ago. We looked for centers that were willing to do DCB interventions. And you see on the left lower corner, this is Switzerland, and we found just 4 centers at that time. My own center was University Hospital in Basel. There was some satellite. This is Liestal. This is a little cath lab outside. Then there was St. Gallen and Lucerne. And these four hospitals were willing to participate in the studies. The other one said, no, DCB, what is that? We don't use it. A couple of years ago, a year ago, I changed the position from Basel to Zurich, and when I came to the new hospital, no DCB at all. There were barely no interventions with DCB, and this is a little bit the situation we have. So I was telling you about the Swiss PCI survey, this registry, self-monitored, and the data on DCB in Switzerland is collected since 2019 only, so we have no data from before. The newest data is from 2021, and what I've seen is that the DCB use in Switzerland is stable between 2 to 6% of all PCI cases. And there are lots of centers that use 0 DCB. And there's one center, this is Lucerne, using 26% of DCB. So we have one large hospital doing a lot of PCI. Why is this rate so low? I think the 2021 data, they represent the instant restenosis cases. I think one other problem, it's not standing here, is that we have a financial restriction. In Switzerland, we have the DRG system, so we get money for indications. And if you use a stent, you have a much higher DRG than if you don't use a stent. So if you use a DCB, you don't get the DRG for a stent. The second problem here is that the DCB is 2 to 3 times more expensive than a stent. We pay like 350 francs for a stent, and for a DCB, a good DCB, we pay like 750 francs, so times 3. And then we need more equipment, we need more balloons, we need specialist balloons that are costly, and so forth. And so at the end, if you do a DCB intervention, you might lose some money because you have much more investments for a good result than if you just use a DES. But after all, I think the interventionalists, they have to be convinced that they should use more DCB, mainly in the novo disease. And what Bernardo showed you, the long list of new trials coming, I think this is essential that we build up experience and trust, that we have more faith in what we're doing, and that we believe that DCB interventions is something good for the patient. And if you ask me whether I should be a fortune teller, what is the DCB use in a couple of years in Switzerland, I think that we will end up here. I think we will. I truly believe that with the new trials coming, with experience, with the new data, we will go up to 50% of all interventions that will be covered by DCB. There will be still some interventions by DES, and I think there will be some new bioresorbable scaffolds coming. We heard about this. There are some magnesium stents. The DREAMS generation 3 has some good data. There is the Phantom scaffold with good data. I think that this could be a good thing, and the combination of DCB and BRS with the principle of leaving nothing behind could really be a new strategy. So this is what I wanted to tell you. I thank you for the attention.
Thank you. Thank you very much. So we have some time for discussion. Maybe what is your impression, your questions?
I would like to ask Simon, first congrats for your results of your center, that was impressive. But I would like to ask you, because I'm not sure if the results of your center can be extrapolated to other centers. So I would like to ask you, how was the work beneath this with your colleagues to convince them about the use of drug-coated balloons in all comers PCI? And also, how do you think we have to extend the use of this technology to other centers? Because in some centers you have one interventional cardiologist that is motivated and sure about the technology, but it's hard to convince other colleagues in your cath lab to use this technology in native lesions mostly. And I assume that to extend this to other centers nationwide and internationally is even harder. So.
Thank you. Those are really good questions that I keep being asked all the time, particularly by some of the companies as well. So going back to the first one, which was how did I persuade my department? I didn't persuade them. I checked with them that they were happy that I was doing it. We have regular meetings. We are always showing each other cases that went well, that went badly, or we need advice on. And I talked quite a lot, I always do in those, and showed them some of the cases that I was doing. I think the thing that actually persuades people is they will have a case that they really don't want to put a stent in. They'll give me a shout and they'll say, you know, how could we do this and what do you think, and we'll do it. And they'll realise that really difficult case was actually very easy when you don't need to put a stent in. Then the one of my colleagues, the one that probably most closely followed me, I asked him what really made the difference. And he said what made the difference was actually all these patients coming back to him in clinic and telling him that they were well with no angina. That really, I think that made it for him. And I think then the rest of our colleagues start looking over our shoulders, wondering what we're doing, seeing the results, hearing us talk about it. And because we were quite a polite, gentle, cohesive department. We all gradually went along the same way. So hopefully that answers that question. The next one was, how do you spread it to other parts of the country? So after a long time, we ran a DCB meeting in the UK, the first one a few years ago. Couldn't get anybody to come because there was nobody else in the country doing it. So I basically rang people who were friends of mine in other parts of the country that I knew were good interventionists and friends, and basically asked them to come to this meeting. And within a couple of years, they were on the faculty doing DCB work. And once you get a champion in a hospital, as long as that hospital isn't horribly dysfunctional and split, what tends to happen is that one person will gently, like it happened in my place, drag other people along with them. The other part of the puzzle, obviously, is big meetings like this, more data, more exposure at the big meetings like PCR. PCR this year was an order of magnitude better for DCB than I've ever seen before, but we're still not in the main arena, and that's where we need to be next. I now have a question for Rabban.
I have a question for Simon. There is any lesion or patient where you, from the very beginning, you say, I'm going to implant a stent, I'm not going to try DCB? No. So I start every angioplasty planning to do an angioplasty, knowing that the vast majority of the time it will end with a DCB, but I have these things called stents on the shelf that will bail me out if it all goes wrong. But, I admire, I'm impressed, but for example, if I have a patient that has the only remaining circulation, distal left main, only open towards the LAD, right coronary occluded, 83 years old, 25% of EF, I'm doing the procedure with impeller because I have to do rotablation, and I can treat that lesion with a 3.5 15 millimeter stent. Would you still try first a DCB, or would you go ahead and pre-dilate and place a stent?
Okay, easy answer. We don't have impeller.
Worst case.
Yeah. So we don't have impeller, so that's not a problem for me.
Metaphysical question.
Yeah. I don't know whether you noticed, but at the end of my talk, it clicked on a slide and it said a case, and the case was somebody in their 80s who had distal left main stem stuck on the table with ischemia, an osteal right that was ridiculously tight, and we did all of that with DCBs and some metaraminol to keep so yes, we do. I would start everything with that intention.
I think it's correct what you say. It's correct. It just takes time because to change the set of mind.
I remember this meeting in, I think it was Birmingham the last time I was there, and you showed horrible cases. I was blown away, but I never would have done it. I think he's a special person doing lots of DCB interventions, but if at least we come to 50% would be something. This man is 100% DCB.
It's okay. Bruno?
Question?
Coming back to the initial question, what is the use in different countries? And to be honest, this is completely disappointing, if for Europe at least. I mean, Switzerland is a limited number of centers. In UK, it's predominantly Simon. In Italy, there are a few centers around Milano, I would say, which are using this, and the rest is also almost no DCB. In Germany, we started with everything. It's still 7% of our PCI procedure. Half of it is the 50% of the ISR procedure, and a little bit the novo. So, what is the reason that, for example, if you go to Japan, they have 20-25% DCB per procedure. China is increasing. Is it a different mentality that does not allow the penetration of this technology, or is it Is it that we are waiting for the US guys still, what they will do if they have DCB for the coronaries, or are we waiting for the big opinion leaders that may hopefully change a little bit their mind now? Well, what is the reason?
It really takes time. I was in Seoul 3 weeks ago. I was there for 2 days and a half. I saw several live cases. In not a single case they use a DCB. They did one left main bifurcation with three deaths in a trifurcation. I said this is old-fashioned PCI, and that Korea, SJ Park Center. So I think there is a long way to go. I privately spoke with Greg Stone, and I asked him, Greg, what is your impression of the future of DCB? And he told me, I think ISR and small vessel. No way, ISR and small vessel. That's what he told me.
I just can tell you what we have experienced in discussions with colleagues. I think one is, in Switzerland at least, the money. It's really a big problem. It's really the money. And second is time. If you need 2 minutes for a stent implantation, post-dilatation and finished, and you have to wait 10 minutes and you have eventually to use another balloon, it takes much more time. And so I think this is the problem most interventionalists have. And I think it's just about the data. We have to convince everybody that it's a benefit for the patient, and then it will happen.
Just one point, money is not the issue. In Germany we have reimbursement, and we are still not budget.
So some of that bifurcation data that we will hopefully publish soon, it has a lot of other information in it, such as if you do bifurcations without stents, you use less contrast and you're quicker. And we've separately done a cost analysis based on our huge cohort of patients, and I guess every country is different, but in the UK, the cost per lesion is within about 50 euros between DCB and stenting, and per patient is almost the same, because actually we do more lesions if we're treating them with DCB than if we do with a stent.
But I think that in order to transmit these feelings to non-DCB users, we first need to show cases where usage of DCB makes the procedure easier, faster. Because honestly, I put it on quote, but many interventionists are more interested in their outcome in the cath lab in the time than what was going to happen in 2 years. So if you can show them that with a specific strategy you can do the procedure quicker, sometimes to deliver a stent is a work, it's not easy. It's not that every stent goes in the distal left main. You have to tortuous, so with the DCB may be easier. So I think one first message is to say that in some type of lesion, DCB usage makes the procedure easier and quicker.
I think probably it's very difficult to convince interventional cardiologists are simple. So the technicians that will be simple are more used than the complex technology. So if it is more complex to do DCB, and we have no specific evidence, robust evidence that it is better, it's difficult nowadays to convince that the novo lesion, I think it's clear that in stent restenosis or can be treated, the small vessel has to be treated with DCB, but the other lesions, probably it's difficult to convince the other.
The distal circumflex, for example, to me is a typical lesion for DCB, because the curve with the stent may be, there are many small branches that may need to be protected. The mid and the distal LAD, the diagonal. Let's be a little bit step by step. Before going to the university, let's go to the high school and so.
Specific place.
I have a question for you, that because you have presented the result in left main, and I wonder if when you are treating left main or ostial LAD, ostial left circumflex, you consider the same predilatation a good result, because you can consider a good result when you don't have a type A or B dissection, a 30% stenosis, but when you are treating left main, ostial LAD or something like that, are you more conservative or you keeping the same?
No, we've sort of got our own checklist now of how to do a safe drug-coated balloon angioplasty, and it's all about flow, making sure that the contrast isn't hanging up in the wall, because that's usually a bad sign, and the standard, the dissections that you can leave, just the intimal flaps. And we do the same now in the left main stem as we do everywhere else. But you've got to bear in mind that we started doing this 10, 15 years ago, so it's taken a long time to get from ISR and small vessel to big vessel to left mains, bifurcations, CTOs, STEMIs, etc. You don't just start it all tomorrow. Can I now ask Rabban my question?
Yes, sure.
Earlier on, you said before you started your fantastic study, you weren't a believer. So actually, there's two parts to this question. One, I'm quite surprised that you did the study if you weren't a believer. I guess that makes you a very good scientist. Secondly, at what point did you change your mind and become a believer?
Thank you for saying this. I was interested in a new way to treat a problematic area in the coronary field. We saw the data from drug-eluting stents in the small vessels, and we thought that this is not possible, that they perform so badly. And that's why we looked around, and then the people from B. Brown showed up in our cath lab and said that we have something new. It was not new at the time, but for us it was new. And then we tried it and thought it's a possibility, and that's why we changed it, because we saw an ineffective treatment, and we hoped to see a new way to treat those difficult lesions.
And when did you change your mind?
When?
When did you become a convert?
I think when I saw my own data.
Yeah, saw your own data, or just saw your own patients coming back? So you actually waited until you got your data?
No, it was continuous development. They didn't come back. Just those randomized to the other group came back. But you never know. You're not every day in the cath lab, so you're a little bit skeptic. But when you see the data on the paper or on the screen, then you think, wow, this is a nice.
Okay, we have a last question or comment. Then we need to go to the next session.
Comment, not a question, practically. So you have to go back to the time in which we made the transition between PTCA and stent. What served for this transition? It was the Benestent trial. There were trials replacing anticoagulation with the duality therapy. So we need the evidence for that. On the other side, we have now also guidelines. As long as this therapy is not recommended by guidelines, it will be difficult, I say it. Because these are risky procedures. If something is happening and you are not supported by the guidelines, but to get supported by guidelines, they need randomized trials for sure. So you have to go this path for me.
Okay. Okay, last word. Patrick.
I mean, over the last 3 years, I have been 4 times in court, for people which are nothing to do with Ireland or the Netherlands. It's really across Europe. And I don't have the choice. I have to testify. I got a subpoena and I have to go in court. And it's always more and more cardiologists who does not respect the guideline. Your father died, okay, he had a PCI of 3 vessels, etc., etc. The first question of the lawyer is, did you discuss the case with surgery? Can you prove that you discussed? And it goes on all the time. if they have forgot to take the creatinine before the PCI of the ejection fraction, and it takes hours of question and answer. So it's coming, it's coming. Nothing is mandatory in the guideline, okay? But when it is in red or it's not present, then they say it's not the standard of care. That's what they said all the time. It's not the standard of care. Yeah. So we have to be careful.
Okay. This is a burning debate.
Last comment.
Following on from that, I think one of the issues is, and the reason why we've ended up doing what we've done, is the more you look at the data, the more you realise there is no data. There is nothing telling you that putting stents in everybody saves lives. All that stents ever were supposed to do, as you well know, was get people safely out of the cath lab. And from then they've just been adopted into practice. But actually in those original studies, the acute vessel closure rate was higher in the stent arm of Benistent and stress as compared to balloon angioplasty. And that was before dual antiplatelet therapy. And we all know dual antiplatelet therapy made all of our angioplasty safer, but actually it was stents that got patients out of the lab, and that was what they were designed for.
Yeah.
The rest of it is just about reducing restenosis, and we know how to reduce restenosis. It's good lesion prep and a DCB.
But that's what the guideline, what the standard practice is. It arrived there not following the right path, but it got there. So now we are there. Okay. I love this discussion.
Yeah. We have to close this session. Thank you for the audience. Thank you to the chairman and the expert.
Thank you very much.
Thank you very much, all the people.
The expert and the panelists.